This patient, my patient today is a 27-year-old female. Her biggest comorbidities would be a very strong history of problems, anxiety, bipolar depression. Once she did attempt suicide. This is a hard time for her right now. Yesterday was her sister's birthday, the one that did commit suicide. Her family is still grieving the loss of 3 people that day. Her brother, her sister, and her grandmother. So she's having a hard time right now. Her medications, she's not on many. The pantoprazole and the Pro-Air for asthma. Her fluoxetine, it has been increased to 60 since was sent in. And vitamin D, and she had a Depo-Provera injection on 4/26. She has had 1 of her Hep A's and 2 of the Hep B vaccines. So that's kind of what's going on with her. Right now, her family life is stable. She's living with her parents and her children. She's slightly improved on her PHQ-9, but we believe her contracting was through IV drug use, which the last time was in December of 2020. As we look over her labs, everything is pretty average. Let's see. Her viral load is not extremely high. The only thing, her genotype is a 3, and I don't think we see a lot of 3s in our part of the world. So that's all I have about my patient. Any questions or any recommendations?
Thank you so much. I really appreciate that case presentation. We just have now for time for any clarifying questions. You can go ahead and unmute or chat those in if you have any questions. And if not, you know the drill.
Hey, Rachel, this is John. Do you want to hit the pantoprazole and the Depo-Provera? I'll just talk about therapeutic options. You know, she's genotype 3 non-cirrhotic, so your choices are going to be Eclissa for 12 weeks or Maverite for 8. No reason for any NSFAV polymorphism testing ahead of time because she's not cirrhotic. So I think it's a great person to catch, treat. Sounds like has had a rough existence, and you can do a little bit to help her by removing this piece of anxiety from the equation. And then, you know, depending upon what you can do with the Protonics, decreasing its dosage to, I think it's omeprazole 20, you know, that might make Eclissa a better option as well. And then I don't think there's going to be an issue with the Depo-Provera, but I'm going to defer that to the expert.
All right, yeah, Depo-Provera, that is the medroxyprogesterone, so that is a progestin. So no issues with Maverite there, because remember that concern is with the combined hormonal contraceptives that have the estrogen component and that ethanoestradiol. So this is a progestin only, so you're all good from a Maverite standpoint. And then Dr. Gilfus was correct. The pantoprazole, you just to go along with the way that they were studied in those PK data for. If you would go with the Eclissa route, you would have to change that pantoprazole to omeprazole 20 milligrams once daily. But You know, you could safely use either one of them with the other medications here. So you could use the Maverite, no issues there, so long as she's taking it with food, doesn't have any problems swallowing pills, because it's the 3 pills that she's got to take. And then the Eclissa, you would just have to make that adjustment to that PPI. But both drugs you could use, just depending on her preference.
Okay. Okay. Thank you.
Excellent. Thank you so much. Really appreciate the feedback. Dr. Gilfus, I saw you on mute. Do you have
Oh,
any?
yeah. No, and then long term, you know, you're not going to need HCC screening. She'll be a cure and done. So good time to catch her, good time to treat her, especially of childbearing age. You can prevent any mother to child transmission as well. So good stuff.
Thank you so much. Do you have any further questions, Alice, before we go to the next case?
No, I don't. Thank you.
Great job. Thank you so much. All right. Now, are you ready, Mrs. Blevins? Go ahead and unmute and I will get that up for you. Give me one moment.
Okay, so today I have a 33-year-old female that we're presenting. She came to us through the Inspires program at Southern Highlands. She started using drugs around the age of 13, mostly alcohol and marijuana at first. And then by the age of 20, she was IV drug user, Dilaudid, then went on to cocaine and meth, were her drugs of choice over the last couple of years. She's sure she contracted hepatitis C from that IV drug use. She's not sure if it was from a person, but she definitely thinks it's from the IV drug use. She reports that she's been clean now for 4 months. She's been in and out of rehab over the years, and the longest she's been clean was about 2 years altogether. She's on several psych meds and medications for acid reflux and constipation, and she's also on Spoxon program. We started her on vitamin D because she was low, so we're trying to get that above 60. Her vitamin D is currently 34 right now. She was immune to Hep B when we did her testing, but did require Hep A vaccine. So we started that. She had her first one in March. She'll get her second one in September. She also received her Tdap and pneumonia vaccine. Her liver enzymes were elevated at 301 and 336. The alkaline phosphate is 77. Her platelets were 150 and her iron stage were relatively normal, but her APRI score was 5.017. And her MELD score was 6. Her fibrosis score was high at 0.75. And her child target PUG class is a B. So when those labs came back like that, we did send her for a liver ultrasound, and it amazingly came back with no suspicious lesions or anything like that. It was relatively normal. Robin just wanted to make sure that there was nothing else going on and she needed further treatment from GI. So she has showed some lower leg edema and complaints with that in her hands at times, and severe abdominal bloating. She said sometimes her stomach feels like she's full and that she can't even hardly put her clothes on. She comes into the office sometimes and she actually looks bloated. Robin did it last time she was there, and she's kind of tender to the touch, but the scans all come back normal. So since her labs do suggest cirrhosis, we ordered that liver ultrasound, like I said, and it had some mild enlargement to the right lobe, but no suspicious lesions. And we've talked with her about having a follow-up long-term with GI on her cirrhosis after this treatment's done. She is genotype 1A, so her viral load was 6,360,000. So we thought that she would be a perfect candidate for Maverite 8 weeks. But she also needs to start birth control. So we're going to do that when she comes in for her next visit. I tried to call her yesterday to get in touch with her. We were going to go ahead and start her then, but she didn't call me back. So I'll have to chase her when I come back to the office on Friday. Other than that, that's pretty much it.
Great
She's
job.
relatively healthy and ready to get her life together. So hopefully we can help her.
Absolutely. Thank you so much. Does anybody have any questions right now? All right, recommendations for this patient. I'm going to stop share, but please let me know if you need any of this information pulled back up.
Yes, John. Yeah, it's an unusual case. I'm not sure what to make of her liver enzymes. They're dramatically abnormal. And I think that's making her APRI score and her serum fibrosis markers a little pessimistic, hopefully not accurately pessimistic. And I apologize. I was clicking through the form here and I didn't hear the ultrasound report. You mentioned that their liver ultrasound was normal.
It says that it showed smooth liver with mildly enlarged right lobe, but no suspicious lesions. So that's what we didn't understand, because the complaints she has don't match her her stuff. So
did they by any chance picture her spleen? Because I remember on the exam it said something about possibly a splenomegaly.
the 10-minute study shows. It just mentioned the hepatitis.
Okay. Yeah,
But she's agreeable to any further testing that we would want to do. So if there's anything that you think that we could do to help her, she said she'd be glad to go do it. So.
Okay. Yeah. No. Just I think that her fibrosis marker is going to be falsely pessimistic, but we'll figure that out with time, I guess. She's just so young. It's crazy. To have all this damage, and her platelet count is not that terrible. It's just her transaminases are ridiculously high. So, you know, to my eyeball test, I can't come up with a real prohibition for either of our usual therapeutics. Eclissa, you know, would be 12 weeks. Maverite would be 8. There's no reason to consider Harvoni because her viral load's greater than 8 million. So I'm sorry, 6 million. Her viral load is 6-point-something million. So short course Harvoni would not be an option. And Zepatier for genotype 1A would require some extra testing. So, you know, fortunately Medicaid's got those two on our formulary, the Eclissa and Maverite, and that I'm gonna kind of be thankful we're talking about the didactic we're doing today. I think the interaction of the medicines with a bunch of psych meds, because that's what she has. But I'll defer to Angie if she finds anything on there that looks concerning. But to my quick eye, I don't see anything that would push me one way or another. But now, big picture, before I talk about that, after you treat her, I would just make sure that her liver enzymes normalize. They're just so aberrantly high. If you cure her and her liver enzymes are still high, she's one of these people who could have two things going on. And, you know, if it doesn't get life all better for her after treatment, I'd definitely get her to see someone to work her up for alternative etiologies of liver disease or even GI complaints in general. So.
Well, that's what we were concerned about too, because it's not just this last time we drew it, like the times that we've drawn it to get ready for this presentation, it's just been high.
That's
so
wild.
There's no letting down. Yeah.
Other times I've seen, you know, medication-induced liver enzyme abnormalities are real. Those aren't predictable. They often require a biopsy to really suggest that. But it is someone, if you don't normalize her liver enzymes quickly with your Hep C therapy, then definitely double down on diagnostics and alternative etiologies.
Okay.
I'm going to hedge on whether or not she needs long-term HCC screening. Let's see what, you know, maybe about 6 months after you treat her, if her liver enzymes are all normal and you recalculate her APRI and you redo a serum biomarker after cure and everything's F0, F1, you're probably good. But otherwise, as such, you're left with somebody with a little bit on the cusp, and you might want to consider doing HCC screening for a little while, at least until everything's clarified. So hard case.
Yes, it was. Yes, it was. So
I'll defer to Angie and Rachel on the drug interactions.
As far as the psych meds, given the med list, you're good to go on those.
Yeah, the only thing that you're going to have to worry about here, depending on which therapy you choose, is if you would go with the Eclissa. It looks like she's got the omeprazole on here. The dose is okay. That 20 milligrams. We'll just have to, you know, educate her on the appropriate way to take those, and then be careful. She's got some antacids too. So just avoidance with those with the Eclissa, which might complicate things depending on, you know, when she has her stomach symptoms and things like that. And then with the Maverite, what you mentioned earlier, I kind of heard you say something about trying to get her on birth control. So
Yeah.
if you're going to go with Maverite, she will have to be on a progestin only, kind of like we talked with the first one. So if she wants some sort of long-acting contraceptives, a lot of those are progestin only. So the depot or the implant, so she'd be okay with any of those. There is obviously a progestin only pill that she could do as well. So those are things to consider. You just want to, if you're going to do Maverite, avoid those ethinylestradiol containing combined hormonals. So the normal birth control pills we hear with estrogen are the concern.
Okay.
Even if you did an IUD, if she wanted to go that route, if it's drug eluting, it's progestin only. So that one would be okay with the Maverite too.
All right. Well, that's what I said. I left her voicemail. Normally she calls me back pretty good, so I'm sure she'll get back with me.
Great.
Great. Thank you so much. Do you have any further questions before we move on to the didactic?
No, just appreciate you guys. That's what I told Rob. And I said, oh my God, has the most complicated patient ever for you to take vacation. That's a
No, really do appreciate it. Thank you so much. All right, Angie, are you ready? Do you need me to share my screen for your slides today, or would you like to do that?
I can do it. Yeah, it's
Sure. Let me just, I'll get you co-host capabilities. Like to do whatever you're comfortable with. All right. Go ahead when you're ready.
Okay. All right, are you guys seeing my screen?
Yes, we can see that. Perfect. Thank you.
Okay. All right, so I've got a little bit of a Hep C drug overview, and then we'll talk at the end about the interactions with psych meds. So first drug we have is Maverite. So this is the glecaprevir and the buprenorphine, and this is an NS3/4A, NS5A inhibitor. Works for all genotypes. For this medication, because it has a protease inhibitor as a component of it, it is contraindicated in decompensated cirrhosis for patients. It's taken for 8 to 16 weeks, depending upon previous treatment history and presence of cirrhosis. You're going to take all 3 tablets at the same time of day, and a good recommendation for patients is to pick the meal time or the snack time that's going to consistently work every day for them and be the easiest time of day for them to remember to take it, because as we know with Hep C meds, compliance is key. And the tablets of note cannot be chewed or crushed. This is approved in ages 3 years and up, and we do use weight-based dosing in peds. For most of these medications, I think all of them actually, if they miss a dose, just let them know it's okay to take it whenever they remember it, unless it's time for their next dose, in which case you would just want to make sure that they never are doubling up. For this medication, they can take it even in cases where the patient might have renal dysfunction and there's no dosage adjustment needed, even if the patient is on dialysis. So that's a nice pearl for this medication. There isn't a generic out quite yet. For all of our direct-acting antiviral meds that we'll talk about today, they all have a black box warning that you should monitor if the patient has Hep B before you initiate treatment. And then also their use has not been studied in pregnancy, so it is not recommended for use in pregnancy. And if they are of childbearing age, they should be on a reliable birth control. For the Maverite, side effects were mild. Fatigue and nausea were the ones most commonly reported, but it's really seldomly stopped for side effects. These are pretty well tolerated, very effective medications. And side effects were not noted to be worsened in patients who were treated for longer durations or for worsened kidney or liver functions. So we'll talk about the pellets because this is indicated in children as young as 3 and it can't be crushed or chewed. So the pellets offer a route of administration for our younger patients. So to take them and to counsel the patients to take them, they're going to determine the appropriate number of oral pellets packets to give based on the pharmacy label or what is being prescribed. They should never open them until they're ready to administer them because they do have a window of time in which they should be used once opened. So they should not be mixed with liquids because the drug can actually dissolve pretty quickly and the efficacy can be reduced. What they recommend is that they mix it with the food, and they should not crush it while they're doing that. Don't mix it with anything that's going to need to be heated. And the patient, if they want to drink water after they take their full dose, they can, just not simultaneously with it. So they're going to pour a small amount of soft food with a low water content into a bowl. Things that they recommend include peanut butter, like a Nutella spread, cream cheese, jam, Greek yogurt's a good option, just depending upon whatever the patient likes the most and will be most likely to take. And especially for young kids, it's important to pick something they like because they need to administer it within the 15-minute window. And it should be just try to take it without kind of chewing it or crushing it. And the longer that it sits out, the more bitter the aftertaste is. So if you can get them to take it within the first 5 minutes of mixing it, the better. So the quicker, the better for palatability, for sure. Next, we'll talk about Eclissa, sofosbuvir, and vilpadosvir. So this is our NS5A, NS5B inhibitor. Again, we've got another pan-genotypic option. So this is 1 tablet daily with or without food. And that is important to note. I think we've noticed in past echoes, there are studies that say if the patient has to take 1 pill versus 3, even if it's a 1-time-a-day dosing, compliance is increased, we've noticed, if they take 1 pill versus multiple, which I find kind of interesting, but the studies back that up. So this one is a 1 pill a day. And again, when you have to dose them with or without food, that's always an advantage because dosing them without relation to food does definitely help with compliance as well. Treatment with Eclissa is usually about 12 weeks, but ribavirin can be added or treatment can be extended to up to 24 weeks for certain patients. This one's not contraindicated in decompensated cirrhosis, so that's kind of a nice thing, but it generally does need to be used. Sometimes it might need to be used with ribavirin in cases of decompensated cirrhosis, so that's something to consider. This, again, we should not be crushing or chewing when administering, so it's important that the patients are counseled to that effect. Weight-based dosing in peds, because this medication also is indicated for patients 3 years and up. Headache and fatigue were the most commonly reported side effects for Eclissa, but again, it's pretty rarely discontinued for side effects. It's very well tolerated as well. There is a generic available for this one, and it can be used in patients post-liver transplant. So those are some of the clinical pearls associated with using Eclissa. And again, because we're dosing in patients as young as 3, the oral pellets are an option for those patients. They can be taken with food or they can put them directly in the mouth. So whatever they prefer to do. They can use pudding, chocolate syrup, or ice cream. For Eclissa, they recommend that it's something non-acidic. So let's see, if they want to use it, they pour a small amount, so about a teaspoonful or greater. They want it to be at room temperature or colder, so it can't be anything hot. And you want to gently mix it without crushing it, and then administer the entire mixture within the 15 minutes of mixing. So similar to the Maverite is 15 minutes of administration, and then ensure the entire dose is consumed. They can't save it or reuse any of it if the child will only take part of it. And I think that's part of the reason they recommend just using about a spoonful, because we don't want to have several spoonfuls and then we kind of can't get them to take the whole dosage. So those are some things to keep in mind when counseling caregivers and patients. Next, we'll talk about Harvoni, so ladipasvir, sofosbuvir. So NS5A, NS5B inhibitor. This is for genotypes 1, 4, and 5, dosed once a day with or without food, 1 tablet. Our missed dosage recommendation is similar for Eclissa and Maverite, just don't double up. Harvoni came out in 2014, and this was the 1 pill once a day regimen. It kind of really revolutionized treatment of Hep C. It had great cure rates, setting it apart from previous available regimens. They didn't have to do Pegasus, they didn't have to do ribavirin, so this was a really big thing to hit the market. We can treat patients 3 years and up with this medication as well. We treat patients without cirrhosis or with compensated cirrhosis, again, because we look at the ingredients in this medication, so we don't want to, so we want to look at the indications here. So we can treat adults and pediatric patient greater than 3. with or without cirrhosis, or genotype 1 infection in adult and peds greater than or equal to 3 years of age with decompensated cirrhosis, in combination with ribavirin, genotype 1 or 4 infection in adults and pediatric patients greater than or equal to 3 years of age who are liver transplant recipients without cirrhosis, or in compensated cirrhosis in combination with ribavirin. That's a mouthful, but we're always going to look at the indication before we prescribe, I'm sure. So side effects for this one are generally mild. Again, this is a nice thing to report. Always mild and similar to the other options. Headache, fatigue, and nausea are the most commonly reported side effects. And again, this is a lot different from our previous treatment options. With Pegasus and ribavirin, there were a lot of concerns. And it's nice to have treatment options like this in our day and age since 2014. And rarely stopped due to side effects with this medication again. We've got weight-based dosing again in peds, and there are smaller tablets as well as packets and pellets available in Harvoni. For the pellet administration, we have a little bit of a difference for the Harvoni compared to the Eclissa and the Maverite. So you have to administer it with food for purposes of palatability is what they recommend. If you're administering it by mouth, you can pour the contents of the packet into the mouth and swallow. You don't have to do it with food, it's just recommended. They recommend they don't chew it because it does have a very bitter aftertaste. And again, they can drink water, but after they administer the medication in its entirety. If you're going to administer it with food, which is what's recommended due to palatability, you're going to use, again, a spoonful of a non-acidic food. Their package labeling recommends pudding, chocolate syrup, ice cream, or mashed potatoes. But again, if you're going to go the mashed potato route, remember they're going to have to be cooled to room temperature because you still can't use anything that's hot. Sprinkle the oral pellets over the food and gently mix. This one you have 30 minutes to administer it. So you have a little bit of a longer window because remember Maverite and Eclissa had 15-minute windows. So this one has a little bit longer. And you want to ensure the entire dose is consumed because again, like similar to the other ones, you don't want to be storing it and giving it after that 30-minute window. Now we'll talk about Zepatier, so Elbasvir and Clozapine. So NS3, 4A, NS5A inhibitor. This is approved for genotypes 1 and 4. It is contraindicated in decompensated cirrhosis. Ribavirin can be added in certain patients with NS5A polymorphisms. These mutations make Zepatier less effective. And because this has a protease inhibitor regimen, remember it's only for patients without cirrhosis or uncompensated cirrhosis. If you use it with decompensated cirrhosis, the Clozapine levels can accumulate in the blood and you can have a spike of the ALT levels. Same side effect profile, nausea and fatigue were most commonly reported. We do not have a generic out just yet. Zepatier has fallen a little bit out of favor with use just because of the additional polymorphism testing that's required for certain genotypes and the potential to need to add the ribavirin, but it is still used in certain patient populations. This one has a bit of a different age. It's approved in 12 years and up as opposed to 3 and up. And for renal dysfunction, there's no dosage adjustment needed. So for Zepatier, we don't have the oral pellets because they're not indicated in children quite as young. So Vasevi is our 3-component medication. So sofosbuvir, velpatasvir, and Valoxaprevir. So NS3, 4A, NS5B, NS5A inhibitor. So this is another pan-genotypic option for our patients. So this came out in 2017 and it offered some treatment options for treatment experienced patients who have previously failed on a direct-acting antiviral. So it offered them with an opportunity for a cure. Treatment duration is generally 12 weeks for patients if you're using it according to an on-label usage regimen. Because it's got a protease inhibitor in it, it's only for patients without cirrhosis or uncompensated cirrhosis. Again, we're going to avoid this in decompensated cirrhosis. And we do not have a generic yet. Most common reported side effects are nausea and fatigue, but again, this one is well tolerated as well. So now we'll jump into the interactions with psych meds. So for some of these slides, I have real good news to report. They're easy. But this is a useful tool for everybody to have because you can just pull this up and just know that what you're using is perfectly safe. So no news is good news, no drug interactions are good news as well. But it's important to note these because an article published in the Journal for Clinical Psychiatry estimates that about 50% of patients infected with Hep C suffer from psychiatric illness. So we do have a lot of overlap with not only substance use disorder, but psychiatric illness in our hepatitis C patient population. So these are important drug interactions to take note of when they exist. And some of the slides are not quite as boring. So there are some drug interactions that we do have to watch out for. In the same article, it notes that lifetime prevalence of psychotic, anxiety, affective personality, and substance use disorders are all higher among patients with Hep C compared to the general population. And that was a statistic that's evaluated people in the United States only. In addition to pre-existing mental health issues, being handed a diagnosis of Hep C can be a hard pill to swallow, pun intended, and can bring up feelings of depression and anxiety in itself. So many Hep C patients, they can be out of work, battling in the throes of substance use disorder. Maybe they don't have a strong support system at home, and that can make them more likely to get depressed or have anxiety. So having these conversations with patients can be important, especially if you're their general practitioner and you're kind of handling a lot of areas of their care. So recommendations like joining support groups, talking to friends or family, or practicing self-care are all worthy things to bring up with them, even if it's not time to consider pharmacologic treatment for their anxiety and depression. It's good to kind of get under that issue from the get-go because it can be a hard thing to deal with. And the good news is that this slide is pretty boring, so we'll kind of move on to other slides. But drug interactions are important because oftentimes with Hep C meds, they're filled at different pharmacies. So sometimes they do go through specialty pharmacies to fill these. And maybe they don't have an entire patient list for the patient. So it's always good to get a complete med list of not only what they're taking and prescribed from other doctors and filling at other pharmacies, but maybe even what they're getting over the counter. Like St. John's wort can be used over the counter for depression by some patients. And it's important if they're in the throes of substance use disorder to know what they are using from a substance use disorder standpoint, because those can have some interactions. And I didn't go into those because I know Rachel has covered those in the past very well. So anti-anxiety medications, these are all pretty safe to be using. And a lot of patients do have anxiety that have Hep C. So that's an important thing to note. In the Journal of Gastroenterology, they noticed increased levels of anxiety have been found in Hep C patients with a prevalence of 28% greater than the general population. And of note, in that study, the pre-direct acting antiviral treatment anxiety load was considered to be greater than post-treatment. So it kind of helps their anxiety a little bit to get this treatment taken care of, and just, again, like Dr. Gilfus said, wiping this off of their things to be anxious and stressed about. So that can be helpful to the patient as well. So it gives us an even greater reason to seek help for our patients and to get them to seek treatment. And now that we live in a life and time where the internet's so accessible, it's important to remember too that our patients will often take to Google before they come to the pharmacist and the doctors to open up with them about their questions. So when they go to Google, if you've ever, just Googled Hep C, just to Google Hep C, scary things come up. So words like cancer, liver damage, scarring, it can be really intimidating for some patients, especially ones with not a lot of healthcare knowledge. So they can be dealing with a lot of things in their life and in their mind that they're not opening up about. It can be really intimidating. And some can even be dealing with feelings of shame and panic because, maybe they were an IV drug user 10 years ago, but maybe they've been kind of living a different life right now with a different partner. And maybe they would prefer a lot of the things from their past not be influencing decisions that they're making in their current life. So they might be dealing with some of those feelings as well, and having a partner that they did not know when they were, in the throes of substance use disorder, maybe acquired Hep C. So those are things to keep in mind when we're talking to our patients. So this is our last of our boring slides. I included ADHD because ADHD is just so prevalent and it is considered a mental health diagnosis. Here we have no concerns about drug interactions, but I know especially in the state of West Virginia, we have tons and tons of ADHD. So I wanted to include this just for completeness sake, just so that you have this to look back on as a reference. So now we get into our more complicated slides. So our yellow is an indicator for a potential interaction. So these don't necessarily mean that you have to do a dosage change. It's just something to look out for. Most of the notations are going to reflect non-clinically significant drug interactions. Don't necessarily mean you've got to adjust a dose. Just it's an indication to keep an eye on it and change if an issue arises. The arrows indicate the result of what the possible drug interaction could be. So meaning, for example, we'll look at Maverite and Abilify. So the drug interaction could mean that the Abilify concentrations could potentially be increased. So that's kind of how to read these slides. So first we'll talk about Abilify and Maverite. So Abilify is metabolized by one of the CYP pathways, and the concentrations can be increased, but it is a pretty weak drug interaction. But Abilify does have a little bit of a narrow therapeutic index and can be a little bit unpredictable in some patients. So the recommendation is really just to monitor levels in patients closely for signs and symptoms of toxicity and adverse effects, and then to pivot if they're noticing issues. Same thing with Abilify and Zepatier. So again, we've got a bit of a CYP interaction for the metabolism pathway. Again, monitor closely for signs and symptoms of toxicity. The manufacturers say it's unlikely to be a very clinically significant drug interaction. Looking at Clozapine, we think so few patients are on Clozapine, but there are some still on this medication. So it's unlikely to be clinically significant according to package labeling, but we do have some CYP interactions here. But Clozapine does have some significant toxicities associated with itself as a drug. So in the absence of further testing and a lot of experience with using that, they recommend that you closely monitor the patient for Clozapine toxicities. With Clozapine and ribavirin, so I include ribavirin because in some patients we do add ribavirin. For this, we just want to make sure we're monitoring hematological toxicity with this dual therapy if they're on both these meds. Again, it doesn't mean you can't use them both, just means to keep an eye out. So bumping down to Invega, paliperidone, and Maverite. So there are some metabolism pathway interactions here. Clinical significance is probably not likely, but you're going to monitor again for additional side effects. You're going to decrease the dose because this can cause a potential increase in the Invega if the patient's having issues. For Eclissa, Harvoni, and Visevi, similar story. So they have a similar interaction with that sofosbuvir component. And so you would monitor them for the additional side effects and decrease the dose of Invega if warranted. For Latuda, for use with Maverite and Zepatier, you have a very weak interaction. There's really no dosage change recommended, but if the patient reports side effects, they recommend a dosage decrease be considered based on a risk versus benefit profile, because all of these are risk versus benefit profile, because there can be some major issues with having their mental illness less controlled than it was before they started. So you always want to take it into consideration. And of course, wherever you can treat for a shorter period of time, it's a good idea, because then you get them treated and on their way. We'll bump down to risperidone. So looking at the interaction that it has with Maverite, Eclissa, Harvoni, or Visevi, we've got another weak drug interaction, but unlikely to be clinically relevant, just to keep an eye on the patient. And with Seroquel and Maverite or Zepatier, again, unlikely that it's going to cause an issue, but in certain scenarios, we would say give pause. So some of these scenarios would be if the Seroquel dose is a little bit higher, so for example, over 400 milligrams a day, if the patient's got some liver impairment, if the patient is elderly, or if they have a cardiac conduction abnormality where we would worry about a prolonged QT interval. For those scenarios, we would use caution using these together. So if you have a choice of a Hep C regimen that does not interact and they fit into one of those categories, it would be recommended to avoid the dual use. But it's unlikely that the interaction will be clinically significant in other patients. With our medication, they're mood stabilizers, so these are our anticonvulsants. We do have some contraindications that are important to note. So some anticonvulsants are used for mood stabilization. They can actually reduce the levels of the antiviral, and that's the last thing we want, because we definitely don't want to not cure the Hep C after we try to cure the Hep C. So carbamazepine is our biggest offender. It can be a potent CYP3A4 inducer. Since you're using the carbamazepine for mental health purposes and not necessarily seizure purposes, it might be an easy switch. So you could switch to valproic acid or lamotrigine if the patient does well with that switch. Those would be options to substitute if the patient's open to that possibility. And I included St. John's wort because, again, some patients buy this over the counter, and it does have some drug interactions, not only with Hep C meds, but with other meds. So that's an important thing to get on a med list if they are taking it. But it is a CYP inducer, and it could lower the antiviral levels too. So that's, again, important. We don't want them lowering the efficacy of the hepatitis C medication. And my last slide that I have, this is totally off topic, but there was a little bit of a Cavenova update. So I just wanted to provide that. And so just to review a little bit, Cavenova. It's our first and only long-acting injectable HIV regimen for patients. So the change is that now it's approved for use in adolescents. So that's pretty exciting. You can actually use it in patients aged 12 years and older. You do have to have HIV-1, which is the type of HIV that most people in the United States have. And they do have to be virologically suppressed, which is defined as less than 50 copies per milliliter. And they have to weigh at least 35 kilograms. Again, consistent with Cavenova labeling, they need to have no treatment failures or resistance to any of the component ingredients. And for the adult population, the oral lead-in option is kind of optional, and that they remained consistent with that for the adolescent population as well. And this is an important change because the CDC actually reported that people aged 13 to 24 accounted for 21% of our newly diagnosed HIV patients. So it's a good thing that we have another treatment option for our younger patients. And that is my last slide. Does anybody have any questions for me?
I want to say first off, really great job. Thank you so much. They have some great references now that they can use, and discussing the specialty pharmacies and other supplements that I think a lot of us are naturally trying to take. Like, I'm trying to get into, like, I don't know, reishi mushroom stuff like in my coffee. So you never know. Like kava tea when I was younger and had anxiety attacks, and then I found out sometimes medicine. So it's really an important topic, especially with the correlation with, Hep C patients and substance abuse. Does anybody have any questions or comments for Angie?
No, just great. Thank you.
Well, I'll give you guys some time back to your day. Or Elizabeth, if you have something else to add.
That's
I don't know how
awesome.
many cases there are going to be, so I don't want to talk for too long.
Oh no, we appreciate it. No, we did the silent pause. I know that sounds funny. It's something like Mitra, which she says at the end. I love it. So yeah, if you guys don't have any questions, or if you do, please reach out, and I can reach out to Angie with any of those questions. But I will get those slides to you between today or tomorrow, and then you can have that as your reference. The only announcement I have is on June 9th, Judith Feinberg will be discussing Hep C in pregnant patients. So that should be a good one as well. And I just hope you have a great rest of your week. Thank you, everyone. Bye-bye.